another workflow, immediate dentures. And if I had to pinpoint any of these workflows as being the epitome of you know a reason enough to change to digital dentures, it's for the immediate dentures because the service to the patient is so enhanced with this particular technology for the immediate dentures. So let's look at it. So we could take traditional impressions, no change here. You could take your traditional impressions, use your traditional materials, and a bite registration, preferably the bite registrations at the vertical that you'd like to restore at. But that's what I normally do doing a traditional immediate denture. So no change on the clinical aspect. This could be scanned. And we have our virtual mounting. We could do virtual extractions. So, and what's very nice about this is, and this is a great service to the patient, we could approximate, and that's what it is at this initial point, is, we extract teeth. We do it virtually. We got little tools of extraction. That's great. But we could then go forward and we could design our denture teeth again, being able to ghost in the patient's existing teeth at any time we want. So, and very important again, is to evaluate the patient's existing teeth before they're extracted. Midline, incisal length, all the things we just talked about. Same thing, just evaluate it. They jot down some notes so that the laboratory knows where to start and where the midline, incisal length, and et cetera, where to start. We use that and we ghost in this information at any time using the existing teeth as a reference to help guide the process through the design. What an opportunity. We just don't have that with our traditional flow. Now, going back to the virtual extractions, we could design the denture to what we think is ideal, and we could also ghost in where the extractions were. And sometimes you find you have to go backwards and do more alveolectomy in order to accommodate where you would like the denture teeth to be set. So you could go back and forth on this so that there's no disappointment when it comes to the setting of the teeth. Like, gee, I wish we did it, took more off that tuberosity, or gee, I wish we did this so I wouldn't have to compromise the occlusal plane. Well, we take all the wishing out of this. We have the technology to go back and forth on. What a great service to our patient, and having the ability to ghost in their existing teeth allows the designer to reposition the teeth into a very familiar location for the patient. We do this with our traditional technique, but it's hard. You snap off a tooth, you add a denture tooth, you try to keep it in the same plane, but that's very hard to do. Here, we're doing this all virtually, and we could very much deliver a denture that has familiarity to the patient. In other words, we're putting teeth where they grew, where the existing ones were. Certainly, we're making corrections to them, but we have this information, and it allows the transition denture to be so much kinder to the patient and helps them transition, because there's a definitely better feeling of familiarity. And then again, combine this with the uniformity of thickness of the denture base, and gosh, you've done a nice service for your patient with this, using this technology. So could we do it differently? Yeah, we could also do a intraoral scan, gaining a lot of popularity, especially amongst the younger of us who like to are a little more advanced in the sense of this digital technology, because they played more video games, I guess, than we have. So but anyway, there's definitely an advantage to do a chairside scan, intraoral scan of the patient's existing teeth, and capture this information, then start our virtual extraction. Everything else is the same. It's just a matter of how to get the patient data into the system. So you can do traditional impressions, or if you're more advanced and skilled at doing intraoral scanning, by all means, it's a great opportunity to do this as well. So a lot of flexibility here. So let's go back to our patient. And before we take the patient's teeth out, we look, and we look a little more carefully. And again, I put this chart here to give you a guide of things to look at and to make comments on, because all of these are going to be very important to the laboratory to learn from, so they know where to start, what to make changes in, and again, using this as a matrix, a guide into the process of setting the teeth. So very, very important to improve your communication skills and improve your observational skills, and find a way to make that intelligible to the laboratory so that they could incorporate it into their design. A couple of real quick tips. Impression, you know, you could I like to doing a polyvinyl impression, a putty impression material. This virtual XD putty I love. It's just the nicest clinical putty I've ever worked with, and I like taking an impression with. As long as the teeth aren't too loose or whatever, this works out great because it's got a little extra body to it. So I'm trying to get a denture impression, not necessarily exact impressions of the teeth. But I do need the peripheral borders. So having a little more of a body material like this putty, I could take definitively better peripheral border impressions. And again, if you want to accurize it a bit, you could cut off some of the extra material and do a wash impression to it, and get a really nice impression. If the teeth are somewhat loose, then I certainly recommend going to an alginate. I like a two-phase alginate, one that's got a lighter body that I could inject, and the other I could load the tray with an extremely heavy body material. Same idea, so I could kind of push it up into the vestibular areas. The Accudent XD is the material that I've grown fond of because of the two-phaseness. I don't think there's really too many alginates that got two phases, if there's any that I know of. And then again, we could take some good impressions. So, but that's up in the air. So we could also look at a intraoral scan, as I mentioned, and developing your skill in this area would be probably a smart thing to do. Should we have a surgical guide? Your call. If you do a lot of alveolectomy, I certainly recommend having probably a printed clear surgical guide would be a practical thing to have.